Yes, so my name is Patrick Heck. I'm one of the electrophysiologists from Cambridge, working at Royal Papworth Hospital. We're a cardiothoracic centre, so we've exclusively heart and lungs and 2 EP labs, 1,300 ablations per year, divided amongst the different electrophysiologists there. And we started using the pulse field technology back in June of 2022, and I think we were the first UK centre to launch with it. So I think we have to temper the fact that we're all quite enthusiastic about new technology, but there has to be good clinical evidence behind it. If we're going to be using something on patients, there has to be evidence about both the efficacy of the procedure as well as its safety profile, preferably short and long-term data. And then in addition, I think we also now need to be cognizant of the costs of these technologies when they come in. It's always reasonable that a new technology is going to have some sort of price premium over existing technologies, but as long as that's justifiable either for a patient experience, clinical safety or efficacy, then that makes it something that we can argue the case for. So I think I had a slightly more in-depth introduction to the FARAPULSE system. I was lucky enough to get involved with some of the training from the field safety team as they were being introduced themselves to FARAPULSE. I was like a guinea pig from a physician's perspective in being exposed to that training, which gave me a lot of theoretical insight into pulse field and particularly the FARAPULSE system before actually having any formal training. And then after that, I had the delight of going to one of the academy centres in Toulouse with Serge Baveda and seeing some live cases done by him there with other colleagues, which I think was also very valuable. And with the combination of those two different things, I think by the time we actually did our first procedure in Cambridge, I was thinking, oh, this is easy. I've seen so many of these. I've played with Richard on models. I've seen them in real life. And it all gave an amazingly good foundation about understanding it, particularly how the catheters were going to be manipulated. And I'd say probably it was the first of those two things I found most beneficial, going to the Paris Centre with the trainees at that point, and also speaking with Richard Burrows and how the actual catheter handles on models was very, very useful. It did, and it was very good actually, because I think different centres, different countries, different hospitals, even within the same country, are all going to have a slightly different workflow with a technology. So even though the actual procedure itself might be fairly similar, the preparation for the patient before, during and after has subtle variations. And by sending different ones of us to different centres, we're able to sort of bring all of that information back to us and work out, well, what's good from them that we can translate into our practice and our workflows and benefit our patients. And if we'd all gone to the same centre, we'd have come back with the same ideas, which probably is less useful. So it is always nice to go and see other centres, and multiple centres beneficial from that perspective. So I think the anatomy is quite important with the FARAPULSE system, particularly when starting with it. And we have for a while been cryoballoon users, and I think the value of anatomy might depend a little bit on how you come at this from a clinical experience. If you've been extensively using radio frequency and 3D mapping versus using single shots with cryo, you might have slightly different biases, but we didn't want to do venograms on the table. We would rather get imaging in advance, and so we decided to get CT scans of left atriums on all the patients prior to the ablations. Not that it would change the tools that we were going to use, but it would give us a better idea of the anatomy. We could then overlay it onto the CT scans and get a much better idea of when we were ostial, when we were going to be expecting good catheter contact. Because I think, as is now becoming very evident from additional trials, it is really important to get that position right, and it is a little bit different to the things we've been using previously. And I think the CT scan worked well for us in our workflow. As we've seen here, there are other ways of getting that contact information. Some people it is doing the venograms, other people it's using ICE, some people are using the 3D mapping. And I think you've got to work out what works well for your centre and your workflow. So I think we had a very nice working relationship with our clinical rep. We've known the person for a good number of years, and as a consequence, I think that meant that they as an individual had the confidence to call us out when we were clearly doing things that were not right, particularly when using the new technology, and I think that's important. And so there was an element of respect from us to them, saying they know more about this system than we do at the moment, which isn't always the case. 20 years down the road, it might be the other way around. But to start with, when launching a new system, it was like working with an equal. And so listening to what they tell you, taking that on board and changing, as opposed to thinking, I know best. So I think that was the most critical thing, was respecting the fact they're well trained, they know more about something new for a change, and therefore their opinion matters. I think it's critical for it, really. Whilst there are many similarities to the other technology we use, it is different and it is unique. There's nothing quite like it at the moment. And to help you translate your skills into using this technology, they are very useful for that, because they have seen other people, they've learnt from other people's, maybe not mistakes, but tricks and tips that other people might have learnt and going along their process. So having people who know more about something is always worthwhile. So I think this comes back again to where you start from. If you start from being a user who's used a lot of single shots with a cryo balloon, I think the learning curve is a little bit less steep. It's many similarities in the fluoroscopy and the large sheaths in particular, which is one of the important things. And also the positioning of the catheter. That, I think you will end up with a shorter learning curve if you've come from using large sheaths already. If you're predominantly radio frequency point by point and you're not so used to large sheath, then that probably is the biggest fundamental difference. The safety profile is important to be maintained, and that's about looking after the sheath and making sure minimizing air emboli, etc., and good aspiration. Thereafter, I think the learning curves come quite similar again, but I think if you start with radio frequency, you've got that minor additional hurdle, which is a sheath management, before then getting onto the catheter manipulation. So I think our centre's relatively lucky in that we have a reasonable provision of anaesthetic cover for our list, which is why we are using PFA more readily than other centres. And I think for that to work, it is important to engage with our anaesthetists, because they need to know about how the procedure is compared to some of our other procedures. So things like the procedure is going to be shorter in its duration, but probably a little bit more intense in the discomfort. So they need to factor that into what they will be using to anaesthetise the patient, or maybe using muscle relaxants, etc. And also what to expect in terms of when we are actually delivering the ablation. So it is different enough that it's good to have a small cohort of anaesthetists, talk to them, and then ultimately, once the procedure and once the workflow has been established, they can start to disseminate that learning to their colleagues as well. But having them on board, having the entire lab on board, is always important, but the anaesthetists as well. And unfortunately in the UK, we cannot do the procedures without the anaesthetists, so better to have them alongside. So I think that is one of the biggest strengths probably of Pulsefield, is the fact that plenty of preclinical work's now been done, theoretical work, bench work, and now human data as well, with the larger clinical studies coming out to show that tissue selectivity is very good. We seem to, serendipitously, it seems that the atrial tissue and the cardiac myocytes more generally are much more sensitive to the electroporation energy. And whilst every tissue can be damaged by electroporation, the threshold for the cardiac myocytes is substantially lower than anything else nearby, and some 9-fold lower than neuronal tissue. And all of that together means that it's a very good waveform for us wanting to deliver irreversible injury to the cardiac cells, but minimizing risk of damaging anything else that's nearby. Unlike thermal energy, which unfortunately is fairly non-selective from that perspective. I think that's one of the big drivers, safety. Well, I think that is the million-dollar question from that perspective. I think most of us who started using it think it's very good, it does exactly what it's supposed to do, and as we mentioned earlier, the learning curves are substantially shorter, which probably means that a lot more people are going to be able to get equally reproducible results much earlier on with less experience. That's great, but I'd equally say that many people would also argue that we have very good ways of doing pulmonary vein isolation at the moment, and so what's adding to that? Safety, probably, quicker procedures, both of which are useful, but I think most of us are quite interested in where we go next with it, which is actually saying this isn't going to enable us, hopefully, to take our ablation to other areas of the atrium, hopefully with increased durability and a much better safety profile, which is going to potentially enable us to re-explore many of our own sort of older history of trials where we've had issues with radiofrequency and assessing how effective it is, because actually the ablation tool itself was not that effective. The strategy might be right. So ablating beyond the pulmonary veins and other targets is, I think, where PFA is going to evolve. I think many of us think it might become the workhorse of everything that we use within the EP lab if things keep going as they are at the moment.